sir.
Hello, 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 hello. So then this lecture now is on record. Okay. So again, sepsis. Sepsis. We will discuss about few points of this topic. In fact, honestly, I would like to have this lecture on previous semester because in most of the points, the sepsis pathogenesis, the description of sepsis by itself, it's description, in fact, of the inflammatory response. Anyway, since sepsis is considered as the infectious disease, we put this topic into our module dedicated to infections. Anyway, if you may know, the general principle of the infectious disease, that's so-called Koch Principle, Koch triad, that in real infectious disease contributes several features, and one of the features of the infectious disease that must be caused by one certain pathogen, one certain bacteria. So in fact, we may conclude that one infectious agent, one pathogen, must induce one infection disease. In contrast to that, sepsis is staying aside of this conception because, in fact, sepsis could be caused by different pathogens, and you will see that here. Anyway, since it's caused strictly associated only with the infectious agents, that's why we consider sepsis as the infectious disease. Okay, Muhammad Shalabi is coming. Hello, Muhammad. So the sepsis definition is here. That's, as you may see, potentially life-threatening condition caused by the excessive body's response to an infection. In other words, that's the systemic illness caused by microbial invasion of normally sterile parts of the body. Do you got it? So you see, normally sterile parts of the body. So in fact, in contrast to the gut, in contrast to the oral mucosa and even airways, which are containing the normal microbiota, the appearance of the bacteria, appearance of viruses and fungi in the normal sterile parts potentially may cause the sepsis. And let's figure out why in some cases the bacteria, the viruses, that produce only local effects, but in other cases they produce the systemic effect like this. So first of all, you must accept this general rule and don't misinterpret the fact that sepsis doesn't equal the bacteremia. So sometimes it's very easy to imagine that the appearance of bacteria in the bloodstream means the development of the sepsis. And in most of the cases, that's true. So bacteremia of such bacteria like Staphylococci, Escherichia coli, and others which are potentially dangerous for the sepsis development, yeah, they are strictly associated with the bacteremia. But in certain cases, the bacteria which may appear in the bloodstream, when we see bacteremia, for example, in case of the typhoid fever, they are not associated with the development of the septic condition. Anyway, sometimes it's true, sometimes not, but generally, archaic subtypes of the sepsis are here. The septicemia and septicopemia, and in a lot of the MCQs of Koch 1, you will see the this term terms as the septicemia and septicopemia. So in fact, few decades ago, sepsis was considered as the development of the systemic inflammatory response against the bacteria. Okay, people, somebody is talking together with me, or it's just reverberation again. That's very, very noisy. So now it's quiet. Good. So anyway, in some cases, the systemic inflammatory response during the sepsis could be very high, of very high level, and in such a way, they conclude this type of sepsis as the septicemia. So septicemia is basically associated with the excessive immune response and excessive systemic inflammatory response. That's the septicemia. In contrast to septicemia, septicopyelonephritis is associated with quite moderate or mild systemic inflammatory response, but that's why production of my voice leads to this reverberation. I guess, first of all, I want to pause. So, well, once again, septicemia is basically associated with the excessive systemic inflammatory response. In contrast to that, septicopyelonephritis is traditionally associated with the dissemination of the microabscesses around the body in different parenchymal organs, like as you may see on this image in the kidney. We see the so-called apostomatous pyelonephritis, which is basically associated with the hematogenous dissemination of different infective agents like staphylococci, E. coli, etc. So, as you may see in case of septicopyelonephritis, we see the formation of small abscesses in many organs. According to an entry portal, we may classify the sepsis into different subtypes. For example, in case of then the portal entry of the microbes is located within the kidney, within the urogenital tract, we call this type of sepsis urosepsis. The same principle for gynecological sepsis, vasogenic sepsis, basically associated with the injections, for example, in the drug users. Infectious endocarditis, also associated with the vasogenic spreading of the sepsis, but of the microbes. But infectious endocarditis, in contrast to vasogenic sepsis, basically infective endocarditis is associated with its own etiology and pathogenesis. And cryptogenic sepsis, which is by itself the sepsis without clear cause, without clear or certain causative agent, causative form. So you don't even find the portal of entry of the microbes. So you may find the difference here of two different types of pyelonephritis. For example, on left, you see the formation of the septic pyelonephritis, hematogenous pyelonephritis with the disseminated microabscesses. In contrast to that, the pyelonephritis, which is developing through the vesicoureteral reflex or due to the other different derangements of the movement, passage of the urine from the ureter, basically is developing locally within the kidney. However, then the forces, invasive forces, infectious forces of the bacteria is surpassing the defensive forces of our body, the bacteria may spread to blood and potentially may develop septic condition. Here you may see the examples of factors affecting our body, and in such a way demonstrating the different clinical features depending on the site, depending on the pathogens. For example, very potent pathogens like Streptococcus pyogenes and streptococcal pyogenic exotoxin, which is produced by this bacteria, even with the infection of the skin, may lead to the septic conditions, which could be concluded into the development of toxic shock, or in this case, we will rather call it septic shock. Different intestinal bacteria like Salmonella typhi, Salmonella typhi may develop the septic condition. The same for the Klebsiella pneumonia, which is by itself got the very strong potential of the abscess development in the lungs, also may lead to the development of the septic condition. Susceptibility to the certain bacteria like Streptococcus pneumonia also may demonstrate the certain sensitivity to the development of the septic condition. And the temporal evolution of such bacteria like Neisseria meningitis may also lead to the development of certain forms of sepsis. As you may see, sepsis is mainly associated with the with the bacteremia, with the bacterial infection and dissemination, general dissemination of bacteria by the blood. By honestly saying, that's not only the pathogens that may lead to the sepsis. Fungi, viral infection that you will see later also may cause the septic condition. Anyway, vast majority of the cases indeed associated with the bacterial infection. And here you may see the two major groups of the bacteria, which we are traditionally classifying by their capability, their ability to stain by gram-negative and gram-positive bacteria. As you may know, the gram-negative and gram-positive bacteria demonstrate different patterns, different features of the bacterial wall structure. And then bacteria, doesn't matter gram-negative or gram-positive, is encountering to our immune system. Our immune system finally is irritating by the external components of the bacterial wall. And this irritation finally leads to the triggering of the inflammation. You remember the inflammation, you remember the inflammatory reaction, acute inflammation, for sure in this case. But okay, somebody appears without muting. I want to mute you, my friend. Don't worry, I will turn you back later. Good. And you may see the so-called pathogen-associated molecular patterns, which in fact irritate our immune-competent cells. First of all, neutrophils and monocytes. So in case of the gram-negative bacteria, that's lipopolysaccharide. That's the substances that the neutrophils and monocytes got the first encounter with, and the lipoteichoic and the proteoglycans, the lipoteichoic acid and proteoglycans on the surface of gram-positive bacteria. So these pathogen-associated molecular patterns, or PAMPs, remember this abbreviation, PAMPs, they produce almost equal effect on our immune competent cells, macrophages and neutrophils, and secondly, to the irritation of the macrophages and neutrophils, they produce so-called first wave mediators of inflammation. You must know them, that interleukins 1 and 6 and tumor necrosis factor alpha. Also, these pathogen-associated molecular proteins produce cleavage of component complement 3 and trigger release of C3A. So you already know that from the infection, from the inflammation topic, what is the difference in sepsis? So that's what I already told you, that sepsis and septic conditions strictly associated with the inflammation. But in this case, we have deal with the systemic effect. We have deal with the systemic release of interleukin 6 and 1, TNF alpha, and competent complement activated. So, and this systemic release will lead to the strong downstream effect as the septic shock. Septic shock is like the ultimate stage of the sepsis development. So the causes of septic shock, as you may see, that's coinciding with the causes of sepsis. Gram-positive bacteria. You see here most common cause. In fact, today I recheck the incidence of the sepsis, septic condition, and figured out that there is a certain evolution in the incidence and the balance of incidence of septic condition between gram-positive and gram-negative organisms. So in the pre-antibiotic era, the most frequent cause of the sepsis was focused basically on the gram-positive bacteria. Gram-positive bacteria develop the vast majority of the septic conditions, majority of the sepsis incidents. Then, after invention of the antibiotics, some antibiotic resistant gram-negative organisms like Pseudomonas aeruginosa raised them head, and finally started to produce more cases of sepsis, and that's why in the 60s, 70s of previous century, the 20th century, we have seen the predominance of gram-negative sepsis. In 19th, the development of the antibiotic resistant cocci like Staphylococcus, Streptococcus also started to be associated with the prevalence so, of gram-positive sepsis. So we may call this gram-positive sepsis strikes back. Well, you see causes gram-negative, gram-positive bacteria and fungi and even viruses. I included SARS-CoV-2, and that's true. In fact, everything what we may see in the pathogenesis of COVID is basically associated with the secondary response, secondary changes in our immune system and excessive response of our immune system against this virus. And indeed, we see the cytokine storm that's in fact one of the features of the septic shock in the septic condition. Notice that infections localized to a specific tissue can trigger sepsis even without detectable spread to the bloodstream. So sometimes we may see that release of the pumps may be produced even without the bacteremia. So that's why I told you sepsis doesn't equal bacteremia, because in some cases bacteremia is not associated with the sepsis. In other cases, absence of bacteria but presence of the endotoxin. Once again, what is the endotoxin? That's it, guys. Endotoxin, that's the components of the bacterial wall, may lead to the development of the septic condition even without sepsis. So I got some message on the chat. Yes, I already added the students. All the participants are here. So look, the counterpart of the bacteria, the immune components of the immune system responding to the bacteria, which are appearing. Okay, we are running out of time. Yeah, so I'll try to upgrade it. So then you see macrophages, neutrophils, dendritic cells, endothelial cells, soluble components activated by microorganisms initiate a number of inflammatory responses that interact in a complex, incompletely understood fashion to produce septic shock, which is similar to systemic inflammatory response, that's CIRS, that can also be triggered in the absence of any apparent underlying infection. So factors contributing to the pathophysiology of septic shock. First of all, inflammatory mediators. You may see here the first wave mediators, second wave mediators. I already pronounced them. Endothelial cell activation and injury, which finally may lead to the thrombosis, increased vascular permeability, and vasodilation. Pro-inflammatory state associated with sepsis finally leads to the widespread vascular leakage and tissue edema, which deleterious effects on both nutrient delivery and waste removal. So ischemic injury produced by the septic shock. Metabolic abnormalities, immune suppression, and organ dysfunction. That's finally the other effects of the septic condition. So briefly, in this schematic, you see the pathophysiology of the septic shock. Once again, everything is triggered by microbial products, and you see the downstream effect. The first line of defense, neutrophil and monocyte activation, endothelial activation, and triggering of the coagulation system, finally leads to the second wave of the effects with the microvascular thrombosis, vasodilation, different other systemic effects like fever, diminished myocardial contractility, metabolic abnormalities, immunosuppression, tissue ischemia, adrenal insufficiency, and finally multi-organ failure. You see that the net effect of these abnormalities is hyperperfusion and dysfunction of multiple organs. Tightly associated with the septic shock, there is another condition that we already passed in previous semester, that's DIC, disseminated intravascular coagulation. Also, it's pathophysiology demonstrated here. Another effect of the systemic inflammatory response, that's the acute respiratory distress syndrome. We already passed it during the topic of pulmonary. We still have incoming students. That's okay. We already got 40 participants. It works. I just want to anticipate some disruption of our abruption of our lecture. If we will have the issues with the time, I will start the lecture again, and in such a way we will have two parts of this lecture, okay? So please hold on line when the lecture will end. I mean this part, because we got only 40 minutes, and we will start the part number 1, okay? So don't worry about that. Yeah, still 41. Good. So acute respiratory distress syndrome, everyone talks about that now because it's associated with COVID-19. So what is that? Just to repeat, acute respiratory distress syndrome, that's the clinical syndrome of progressive respiratory insufficiency caused by diffuse alveolar damage. That's sometimes the synonym of acute respiratory distress syndrome, DAD, diffuse alveolar damage, in the setting of sepsis, severe trauma, or diffuse pulmonary infection. In case of the COVID-19, we got the sepsis-like condition for sure. Neutrophils are and their products have a crucial role in the pathogenesis of respiratory distress syndrome by causing endothelial and epithelial injury. And the characteristics you may see on the histological picture. That's the schematic of the development of acute respiratory distress syndrome. And what you may see the systemic activation of the neutrophil, finally the sequestration and migration into the alveoli, and finally damage of the alveolar epithelium due to the release of different factors like leukotrienes, TNF, interleukin-1, and interleukin-8. Desquamation of bronchial epithelium, necrosis of alveolar sites, together with the increased permeability of the vessels, lead to the formation of hyaline membranes. Basically, the respiratory distress syndrome consists of two major phases. That's the acute phase. Then we see the alveolar macrophages release interleukin-1, 8, and tumor necrosis factor. That leads to consequent polymorphonuclear leukocyte or neutrophil activation. Then the release of secondary mediators, damage of local tissue damage, accumulation of edema fluid, and development of hyaline membrane. And after that, if the patient survived, if you helped him with the intubation, with the oxygenated, with the respiratory support, with the ventilation of lungs, we may see the development of healing phase. Then there is the release of macrophage-derived fibrogenic cytokines and different growth factors which stimulate the fibroblast growth and collagen deposition associated with healing phase of injury. Anyway, we may see that's the first phase, diffuse alveolar damage and formation of the hyaline membrane. You see the multiple neutrophils, you see the hyperemia in the vessels, and that coincides with severe respiratory failure. Finally, healing stage, you see the development of the fibroblast proliferation in the interstitium. You see the regeneration of the alveolar site, still some remnants of the hyaline membrane, but in the future, it would be resolved because of the potentially could be resolved by the remodeling of the connective tissue. So there is the hope that this patient could be healed after all. But in this case, since we got the post-mortem section, it didn't happen, unfortunately. That's always the respiratory distress syndrome. Another feature of the septic condition, and particularly disseminated intravascular coagulation associated with the septic condition, there's the Waterhouse Frederickson syndrome. he already passed this topic. It was the bacterial infection, and particularly Neisseria meningitis infection. And these bacteria, exactly these bacteria, is guilty in the vast majority of the Waterhouse Frederickson syndrome. So we got less than 1 minute of this lecture. I just want to stop it and start it again. Okay. So see you on second part, please.